and I will turn it over to our hosts today, Karen Odell-Barber, founder of Neurologics, and Dr. Dallas Hack, chair of the Scientific Advisory. So Karen, take it away.
Sure. Thank you so much, Cody. And thank you, everybody, for taking time out of your busy day to join us to talk about brain mapping and optimization. I'm passionate about this, and you can see that this is me on the left-hand corner. A younger version of me, probably 6 or 7 years ago. I founded Neurologics actually 14 years ago. And it was, for me, the perfect intersection of bringing scientific, diagnostic, core technology to the field of behavioral medicine. And that had always been a passion of mine. I've always been really interested in complex cases and worked at a neuropsychiatric center and ended up running the neuropsychiatric center. And I'm passionate about the intersection of health and brain wellness with treatment. Just as a sort of a quick summary, in the beginning, it was hard for me to wrap my head around who needs neurologics. What kind of clients do I have that would benefit from brain mapping and optimization? And it took me probably 1.5 years to fully wrap my head around the comprehensive diagnostic abilities of brain mapping and also the benefits of optimization. And so if you have cases like I do, you think of us for recidivism, for clients who keep on coming back over and over again, for clients who arrive at your doorstep with competing diagnoses or testing that's incongruent with previous testing, or members of the outpatient team that disagree, or even parents who disagree about a diagnosis. School avoidance, obviously, learning differences of all kinds. Perhaps we're best known for traumatic brain injury and concussion. We work with both professional and collegiate athletes on a regular basis. So when people think of our brand, they often think of us for TBI and concussion. ADHD assessment has become more and more popular, especially with parents growing more and more concerned about the use of stimulants in children. Substance abuse, we work with substance abuse cases routinely. However, as a disclaimer, I want to say that we do that in conjunction with substance abuse treatment centers. Where we are not saying that, hey, substance abuse can be treated solely with use of neurologics, but it is a wonderful complement, and we're peer-reviewed in both traumatic brain injury and concussion and for our outcomes in addiction as it relates to relapse. When we talk about addiction, we talk about process addiction, and that means gaming, pornography, excessive online shopping. All forms of process addiction live in the same kind of the part of the brain, the cingulate gyrus, that substance use disorder lives in. And then we like to talk about medication-free or reduced treatment plans. Why I'm passionate about this, I talked about this to begin. For years, we believed that learning differences were unmendable and static. And for me, I always looked at charts, and this is kind of hearkening way back to my psychiatric hospital days when there actually was such a thing as a paper chart. Looking at charts and looking at, gosh, this person has so many different diagnoses and such an extensive treatment history, and we're trying to come up with a treatment plan, but do we really have the core or the root of the problem identified? And I operate from the core belief that you can solve any problem and devote resources to any problem if you actually know what that problem is. I would say that in addiction treatment, outcome numbers are no longer acceptable. They've been the same, they've been static since the 1960s. And so for me, I did my postgraduate work in addiction and eating disorders. I've always been hungry for the ability to improve outcomes. We've always been sort of the go back to the last slide, Cody, sorry. Thanks. We've always been the stepchild of true medical treatment. And for me, it always struck me that you would never think of offering up a treatment plan for a joint that needed to be replaced or a broken bone without imaging and without really looking at, here's what's wrong, let me show you using this imaging, let me show you where the bone is broken. Let me explain to you how I'm going to use pins to fix that or reapproximate the bones. Do you see where the problem is collaboratively with the patient and the guarantor? And do you understand and agree with the treatment plan? It's much more murky in behavioral medicine. And for me, I've always been passionate about brain mapping because it's a scientific data point for all of us to align around. And then when we talk about neuroengineering, which Dr. Hack will do later, we have for the last 14 years greatly improved learning and behavioral outcomes. For me, it was an enormous paradigm shift to be able to say, okay, when we're thinking about a diagnosis, what we as clinicians are trained to do is look at things above the waterline, point at those things and call them a name. And so we are looking as providers at what's above the waterline. This is looking at what the root cause of the labeled DSM diagnoses above the waterline is, using real-time brain activity and connectomics and an engineering analysis to get to the root cause of what is the cause at a brain-based level of those features above the waterline that we identify, label, and name. We look below the surface, we analyze the whole iceberg. People often ask me what the difference between neuropsych testing and brain mapping is. Often when people come for neurologics assessment, they've tried many other things, and they often have neuropsychological testing. Neuropsych testing is paper instrument testing and employs standard test batteries. It's paper instrument testing, and it can be biased and subjective, and it's limited to interpretation of scoring against norms. It's notoriously imprecise for diagnostic purposes, and so this is different than that. This is scientific analysis without tester bias, using QEEG and dynamically adaptive software, which is proprietary to Neurologics. There are continually benefits from understanding of the connectome, and it not only employs the scoring against the norms, which is Z-scoring, but also within the subject controls. It's real-time data, and what that means is we look at the brain as it is thinking at the actual speed of thought, and then we do a process called discriminant matching. And so we use elements of the Woodcock-Johnson and elements of neuropsych testing, and we compare those to normative databases, NIH, NYU, and ours, which is the largest abnormal brain database in the world. This provides much higher precision, and it's more objective than paper instrument tests. So people ask the provocative question. We were at an educational consulting conference recently, and a number of educational consultants said, can this replace psychological testing? The answer is yes, because the information you're looking from neuropsych testing is incorporated into the brain mapping and its subsequent report. I like to talk about building a house when it comes to treatment. So often when you're looking at putting someone into a treatment center, into a course of residential treatment, even into an intensive outpatient program, you're talking about giving them wonderful tools in a framework. And I believe in treatment. We partner with treatment centers. We map routinely in treatment centers. We map in wilderness. Looking at how we work with those treatment centers is equivalent to building a house. And when you think about brain and its function, it's foundational for everything else. The brain is the concrete. And so you can have the most wonderful program in the world, but if you're sticking those wooden uprights into dirt without concrete, the issue is that people can't remember, retain, or withdraw the tool from the toolbox at the right moment. So it could be a framework of personalized private school. It could be a framework of addiction treatment. It could be eating disorder treatment. It could be a therapeutic boarding school or a residential program. What happens when you look at the brain as the foundation for treatment is that those two pieces work together. And once you have that concrete foundation, you can put the uprights in and you can build the frame using the solid foundation, and it gives you enough to put a roof on and doors and windows and build the house. It's now my great pleasure to introduce you to Dr. Dallas Hack, who chairs our scientific advisory board. Dr. Hack was a gift to us through the NCAA, the medical director of the NCAA in 2019. We had forged a friendship, and he said, look, Karen, if you'd like to take this to the next level, the person that you really need to chair your scientific advisory board is Dr. Dallas Hack. And I looked just like you're looking at his decorated military veteranhood and his scary battle fatigues. And I thought, how in the world will this person intersect with neurologics? And I will tell you that, for a lot of coaching, he flew across the country to observe the brain mapping process and did a tremendous amount of due diligence on neurologics before he agreed to join us in a meaningful way in 2019. If you look at his impressive resume, this is just scratching the surface. His CV is truly one of the longest I've ever seen. And he's tremendously skilled and gifted. And the part that struck me the first morning when we had breakfast and I was trying to consider or understand how we would work together is just how deeply he cares about providing care for the greatest number of people. It doesn't appear on his CV, but I will tell you that he has 7 children, 4 of them are adopted, and there is a 40-year span in their ages. So to look at the scary battle fatigues doesn't begin to tell you the kindness of the man I'm about to introduce you to. So it's my great pleasure to introduce you to Dr. Dallas Hack.
Oh, thank you so much, Karen. It's been a privilege. I'm very blessed to be part of this. So as Karen mentioned earlier, with most people think about assessing some kind of an organ system by some kind of an medical image, X-ray, CT, MRI, or whatever, and that's what we have for the brain. The MRIs, CAT scans, and some other circuits. So what the problem with all of these modalities really is they don't assess function. They tell you about the structure of the brain, but what's unique, the brain is the most complex organ in the body. And the modalities that might work good for a bone or some other organ don't work well for the brain because they don't tell you how the different tracts in the brain are used. They say they show you a tract, but they don't show anything about what it does or how well it's doing. And so the MRI gives you sort of a picture of the soft tissues more. The CT scan gives you a picture whether you have a bleed or not. And so on. The SPECT scan is used by some folks. It tells you a little bit about circulation. The use of a radioactive substance that's injected into your vein that then goes to your brain and tells you a little bit about the circulation there, but it isn't really telling you about how the nerve tracts are being used. And so these are limits. They're expensive, they're big, and so on. So we'll go on to the next slide. So on the left, this is a picture of from a very high resolution MRI called a DTI, and again you see these pathways and so on, but you can see the physical structure there, but you can't again understand from this how it's being used on a thought by thought or action by action basis. I mean, what we need is a much more functional thing that with a standard stimulus, you get a standard emotional or standard cognitive process, and then a cognitive response. And that's that's the ideal that the field is missing in terms of how the brain functions. There is a version of MRI called functional MRI, but it still doesn't get you down to the tract by tract basis. It just gets you to regions, and the brain doesn't work by regions. It works by pathways, by networks. So the next slide. This, and thus forward to what the value of measuring electrical activity. That is actually an indicator or an external representation of the brain at work. If you're some people, I mean, quite a number of people are doing EEG assessments, and they're looking, you know, from that you're getting some, whether it's a seizure or not, or you're getting point by point activity, how high the voltage is on each point around the brain, but that even doesn't tell you how the brain is working. You need to be looking at the brain networks, how the connections are working within the brain. And so you can see here, I mean, relatively lightweight, a cap, a small device to measure it, portable, and so on. And what you can do with this is what's unique about the Neurologics approach is the extensive activity, the standardized 17 different brain activities that are used, and then people's brain network function is measured while they're doing those activities, for putting the brain under task. Simple, you know, if you're trying to understand how well a person's brain is working, how can you do that if you don't measure the brain while it's working? If you're measuring the brain at rest, it's not doesn't tell you much about what it's doing while it's working. And so you can see from the portability here, it can be taken to anywhere. You know, again, as Karen mentioned, your home, boarding school, wilderness, and a variety, obviously other institutions or offices or whatever. So next slide. And this is where some leading up to this is that, you know, not all brain maps are equal. There are a lot of people who do these, what they call brain maps, but these are passive brain maps that are measuring point by point activity. With this technology is measuring across, it's a 2-hour long process. A lot of those other processes do theirs in 5 or 10 minutes. This is a 2-hour because it takes that to put all of the different networks under defined patterns that you can measure their patterns against a big database, the largest active state database that exists in the world. And then comparing that individual's data against this large database, and then we know what the patterns are of a person with anxiety, or a person with depression, or a person with emotional lability, or, you know, the different symptoms that are defined from the neurocognitive assessments. We actually know what their brain patterns look like in response to these 17 different neurocognitive exercises that we put them through during the map. Next slide. So what's generated from this is, and comparing them against that database, is that we actually can put numeric values to these different functions. We don't measure how well they're doing on the individual test. What we're measuring is the electrical activity while they're doing the test. Fundamentally different. And from that, and then again, in response to this database of tens of thousands of people, that we can measure how well are they overall functioning, their thinking ability, their fluid reasoning, these various different cognitive processes, cognitive measures. What's their processing speed, spatial relationships, and you get into some of these other ones of these various indexes. And these are all based upon measuring electrical activity and comparing them against the big database.
And I'm going to be the layman introduction here, right? Yeah. So I'm going to say that when we created this, it used to be 32 pages long, and it was an 8-point mouse type. And understanding that people learn differently, and I'm certainly one of those people, it was sort of like, okay, how do we make this so easy to read that in a multidisciplinary way, we can look at this report in 5 minutes or less and be able to make sense of it. I'll go through that in a little more detail later, but we set it up like a traffic light. Green is good, yellow is caution, red is not good. And I was not anticipating the need for a fourth color. Everything's normed to 100. So as you can see, those things in the 80s give you reason for pause. The blue is gifted, and I, the 14 years ago, probably about a year and a half into it, I had a parent say, okay, I understand through the optimization process, everything's now reached green, but how much longer until my child can get into the gifted range, or until I can get my gifted brain back? And way back when, I didn't know the answer. And the answer was, if you have the genetic potential for giftedness, we can get you into the gifted range. So that upper line IQ, that top line IQ, not under stress in a perfect world, is a number that represents learning in a perfect environment where there's no ambient noise, there's no stress. And if that number is impeded by something like traumatic brain injury, substance use disorder, a number of other pieces, and that number hovers around 100 and actually has the potential to be gifted, an optimization process can take someone not just into the green, but into the blue. Sorry for interrupting, Dr.
No, very good. If you can go back just a second, please, Peter. Thank you, Cody. So this, this brain map process and the use of this database just gives us an assessment of how the individual is doing. And as you can see, there are some of these are gifted measures, and some of them have areas, but by measuring the specific network connections within the brain, we can determine on an individual connection basis between the different parts of the different networks which ones need to be strengthened, optimized, balanced, or even decreased to put everything in balance. And that is the fundamental part that's used to then generate an optimization program that's based upon different specifically selected cognitive exercises that activate, that it's like going to the gym. It works out, specific sections of it repeatedly. And when you do that repeated activity on a nerve pathway, it's much like strengthening a muscle by repeated activity. That nerve pathway strengthens, and so on. The basis of which ones need to be worked on is based upon building from the foundation up and knowing which specific circuits need to be worked on. Neurofeedback will give you some on a localized voltage level basis. It'll increase or decrease your voltage temporarily, but it doesn't give you this network function change. And if you do that for the appropriate amount of time through the program, you can generate permanent cognitive change with that, not just temporary symptomatic relief. With that, go into the next slide, and Karen, you.
Sure. So this is the report, and this is the top page of the report, and it's about 10 or 11 pages long now, and it's set up in a multidisciplinary way. And so if you look at the report highlights, for me, it was about, I've been a hospital social worker. I've done therapeutic practice in an outpatient way. I've worked within psychiatric facilities and treatment centers. And what I need to know, I have about 5 minutes to look at. So if you're looking at the report highlights and you have 10 of these to stratify, you look at the top line IQ for this report and you say, okay, their current functional IQ is 99. And so that's slightly above normal. Oh, sorry, slightly below normal, 1 point below 100. But they default 2 standard deviations when they're under stress. And so the idea over and over again is, hey, how do I learn in a perfect environment? That's the top line IQ. And the second one is, and what access do I have to that big brain when I'm under stress? When I'm driving down the freeway, I'm driving down the 405, and a rescue dog's in the front seat and he just threw up on the floor. Where does my brain go? And for this 17-year-old male, his brain defaults to 80. 2 standard deviations above the top line IQ. And so we all know that when people are in relapse or under stress, when they're using that lower stress default IQ, their decision making is impaired. And the ability to take the tools that you've learned when you go back to this house slide where you're building a house and you're in a program and you know that, for example, if you're talking about a substance use disorder client, the idea is like, okay, when I am stressed, I should call my sponsor. When I am stressed, I should exercise. When I am stressed, I should go to a meeting. But the issue here is that when this person is under stress, they don't have the access to the tools. The ability to self-regulate is also below the functional level of normal, and so is the number that is used to predict relapse. Their emotional recovery number and being present index is also below where we'd like it to be, and that produces a summary of concerns. And those summary of concerns are listed with check boxes. Whether we ask it to or not, the brain is the brain is the brain. So this maps, it started out 14 years ago, it mapped 293 domains of the brain. That then the technology developer took it to 313. When AI came out, that 313 domains of the brain became 3,000. And then within a matter of months, when I was, the last time I was presenting this information, I checked in for understanding with the developer and said, I understand that now we have over 3,000 specific domains of the brain, specific electrical engineering equations. And he said, no, that's not correct. And I thought, oh gosh, I thought I got that information correct. He said, it's 12,000 now. And so between April and July, machine learning took this intellectual property, this algorithm, this mathematical analysis of brain function, and it's now well over 12,000 domains of the brain are analyzed at the speed of thought. And what happens is that comes up with the list of, it's called discriminant matches. And those discriminant matches produce things that we refer to as concerns. So there was a discriminant match that showed us that this client had a medical concern and a trauma concern. And whether this is self-reported or not, what I love about brain mapping is the patient report matters not. It's not taken into account. It's just a scientific analysis of brain function. Dr. Hack loves to talk about the circles and the topographic analysis of brain function. So Dallas, I'll give this one to you because, and again, if anyone on this call wants to go deep under the waterline of understanding how the science, how this works at the connectome level, how synaptogenesis occurs, Dr. Hack would be really thrilled to take you down for part 2 and part 3 way under the waterline. But this is sort of his explanation of the topographic view of the brain and what happens when it's analyzed.
So on this slide, there's actually 2 pages, one of which just as it reiterates questions that they have answered in their intake. So there's some history that's taken, but that's not used in generating the report. It's just to have it all in one place for a simple review by the person that's with the client at the time. On the right, the top 2 rows of the topographical map are the passive map. This is what most people get when they get a brain map. They get a measure to this person. These are at rest, and this is a voltage across each point of the brain of the slow waves on the left, the delta, and then of the faster waves. If you look at the actual signal, it looks like almost a random squiggly line if you've seen what EEG signals look like. But with some advanced math, they can separate out the slow frequencies from the fast frequencies, and they can and then from that understand the voltage level on each one. It tells us more about general brain health than it does really about how the brain is functioning. But this is what most people get when they get a brain map from people that, other people that do brain maps. We start getting into then below that, this is starting to get into the active part so that the rest of the 2-hour brain mapping. And what this is looking at is multiple different analyses. These are 3 of hundreds and more different analyses that are now done on that individual's electrical activity. And so that we start to see, and this starts to show, for instance, the second one is in particular of interest that tells us how hard if the brain's kind of working too hard, if again the ability of the brain to adapt, and whether it's doing all the things that the brain is supposed to be doing, or whether it's having to limit it down to just a couple of them. So it tells us about the word coherence here, and and this tells you about how each part of the brain, each circle, each small circle here on these bottom 3 rows, is a measure of how well that region of the brain is compared to its connections or its interaction with the rest of the brain in comparison to where the normative part. And that's where this large normative database comes in, comparing this individual against tens of thousands of people. And then from all this complex, all this doing these 17 different exercises, it assesses the patterns of activity. That said, as you do those standard, whether it's trail making or different kinds of those neurocognitive tests, there's a very standard way the brain activity occurs while you're doing those tests. And from pattern matching an individual against the big database of people with various symptoms, it tells us whether they have some matches that are similar to people with various symptoms. This individual has a huge number of matches. It just shows that their brain is very disorganized at this point. There's a lot of imbalance going on, and there's a lot of snippets here and there that they're really. The good thing about it is with the optimization program, you very quickly see within a few weeks, you see the brain become much more organized, and a lot of these check marks drop off, and we start to see them really get down to what the core symptoms are. However, to really emphasize, we don't work on the symptoms. We don't work on the check marks. We work on the connections. And by fixing those connections, it then gets the brain hardware working better so that they can then do the tools, use the software that the therapist is giving them better. If they're just getting the software, if they're just getting the tools from the therapist and they don't have the hardware to support it, it's very difficult for them to implement that therapy. It's the combination that works particularly well. So Karen, I think it's still over to you here.
So again, let's go back to the traffic light, and I'm going to speak layperson and say, sorry, go forward. Next slide, Cody, sorry. So if green is good, there's some green if we're looking on the left-hand side. And we're saying, okay, the top line IQ is green and in the solid range. And then there's an algorithm that projects how far we can get this individual. And the part that was so remarkable when I looked at all forms of imaging, I looked at SPECT, CT, I looked at the Dent Institute, I've looked at a number of things before I discovered this technology 14 years ago. Part that was so remarkable was that the brain map doesn't just admire the problem, it predicts how far we can take that individual and how the process of brain repair at the root connectome level can occur. And so across the board, there's never been a client of Neurologics who hasn't made at least 15 functional IQ points of improvement and a dramatic improvement in memory. And if you look at all the millions of the things the brain can do, there's a specific number that if the brain can achieve and accomplish a 15-point bump in functional IQ, that's 1.5 standard deviations. And I was presenting at a treatment center in Malibu, and the medical director, who was new and quite young, said, look, Karen, let me interrupt you and ask a question. Who here in this room cannot use an additional 15 functional IQ points permanently? And that really put it into perspective. It's not about talking about cases and labels specifically. It's about the impact that 15 functional IQ points can have on every person, regardless of their diagnosis, regardless of what label we place upon them. If you can improve memory and the ability to learn and retain material, then you're really cooking with gas. So as you can see on the left-hand side, if we're looking at the second line, that's the projected upper level IQ. for this person that moves from just slightly below normal into the gifted range. And then you look at the both upper and lower level IQ movement that's possible. And then you look at where that person is. So where that person is now is that lower red line of what happens to the IQ under stress. And then you look at what is that stress level IQ, that lower level IQ after optimization. And you can see that the prediction is moving into the gifted range. As Dr. Hack explained, when we're kind of communicating between two worlds, we're looking at imaging, and then we're looking at how does that brain imaging translate into both symptomology and areas to work. And that's the computer checks these boxes. So if you go back to the slide before, Cody, if you don't mind. As Dr. Hack was explaining, there is what really consists of a psychiatric H&P, because we're a technology company that's done online through a portal. It's not done by talking to a human like it used to be 25 years ago. But then as that information is analyzed, the patient or the client concerns are listed, and those are then 1 through 3, right? And a major concern is 3. And there's a whole inventory of questions that takes about an hour to answer. And that information is processed and expressed in terms of what are the patient concerns. Those are on the left-hand side, right? And so if you look at this person, there's no issue with defiance. There's a big issue with task completion issues. They're disorganized, forgetful, they lose things. This is all per their own client report. So they answer a number of questions, and the analysis of that comes up with, what does the client think is wrong? And so number one, it's not a general checkup for them. They have minor concerns with their health. They have no concerns with destructive or aggressive behavior. But this left-hand side really talks about what the patient or client concerns are. And then on the right-hand side, when Dr. Hack's talking about this is a topographic view of the brain, if you actually look at the circles, that the nose is at the front, at the top, and those are the ear clips. And the topographic view of the brain looks at what happens as the brain talks to each other at the connectome level, because it's not looking at each region of the brain as, separate and apart from one another. The way that the brain works is in talking to other parts of the brain and connecting to other parts of the brain. And it is the connections that cause us to be fully functioning as a human. And then as those brain areas are affected, and you see that there's clinically significant areas on the topographic view, the algorithms produce the affectation. So the symptomology at the checkboxes are the brain areas that are affected, the specific areas that are affected, and what the effect of that is. So meaning that this person has cognitive information processing as an effect of their imbalance of their neuroelectric activity of their brain. This person has difficulty with emotional regulation. So that when Dr. Hack was saying, if he were to be giving the report of findings, he would be able to compare the right side of the screen, which is what the brain says, which is what the science says, with the left side of the screen, which is what the client concern or parent concern is. And so the balance of those two things is in looking at, you're concerned about depression, that's a big concern of yours. And then you can compare the emotional concern. The brain is concerned about depression also. The depression box is automatically checked from the imbalance of the brain, which is gathered through scientific information. Next slide. Thanks. So the overview again is, if you're trying to get a quick snapshot of this person's brain, and you look at what are the assets. Those are green or blue. This is this person's initial test date. And now you're looking at, okay, what are the deficits? Those are red. You're looking at what are the big areas of concern. I always look at the red and I say, okay, this person has great difficulty in the neuro recovery index. This person is tremendously relapse prone. The ability to learn, he has some real solid things happening on the learning ability side. He has a lot of green, but he also has some red. And those are specific areas wherein the treatment plan would focus not on what's already working, but in the deficits to get them into green or to get them into blue. This person has low processing speed. That is not red. but it is definitely in the yellow range. So in looking at sort of this person's overall profile, you can then also see that the common behavior expressions, that's the symptomology, is also created specifically from the data collection and the data capture of the neuroelectric activity of the brain compared against normative databases. Next slide. Neurologics has two products. The first one is brain mapping. We just talked about that. The slide had to be updated. We analyzed 12,000 domains of brain function, and that provides the metrics for clinical insight, which Dr. Hack talked about. And then the second piece is like, for me, I want to know what the problem is as a clinician, and I want there to be some agreement using imaging. That's been my life's work, has been how do we all agree on what to do with this case? Because we're looking at the same scientific tool and the same scientific data, and we're coming to agreement around what is the problem using imaging with comparison to large databases. The second piece that for me was profoundly different than anything else I'd looked at was the ability to optimize the brain after you analyze it. So it's not just analyzing, this is where your brain is. It's like a Polaroid snapshot of the brain function at a given point on a given day. The brain doesn't know how it's injured. The brain doesn't know why it's there. The brain doesn't know what you think is wrong. It's just an analysis of the brain is the brain is the brain. It's an analysis of brain function. So what does that do or mean, and why is QEEG brain mapping important? You can use it to deploy resources. So educational attorneys can use it to say, we want to use this brain map to demonstrate to the school district why specialized school is necessary, or why residential treatment for this client is necessary and indicated, and why this should be paid for. Similarly, educational accommodation for educational attorneys use and have used this map for a long period of time to make educational accommodation or an educational plan or adjust an IEP based on brain function. The optimization process is completely separate from the brain map. So once you have the brain map, there is a specific algorithm that creates a treatment plan based on your specific brain. There are no preloaded protocols. My brain doesn't look like Michelle's brain, doesn't look like Cody's brain, doesn't look like Dr. Hack's brain. We all have very unique and different brains. And it is the optimization process that takes a cognitive rehabilitation approach to computer interface, and there's a human being on the other side. Those are sessions that take 4 to 6 months in order to achieve permanent cognitive repair. And that means your brain is fixed forever. It means unless you injure your brain through traumatic brain injury or substance use disorder, you will not need to come back. It doesn't mean symptom reduction. It doesn't mean, hey, every time you want to experience this improved brain, you have to plug into Neurologics or do another session. It means that at the minimum, after 4 months of sessions for 50 minutes, 3 times a week, you will have produced permanent cognitive repair with a new brain. Often we are asked, what's the difference between neurofeedback and Neurologics? I would say that's the most common question that we're asked. And that generally pops into the chat box at, every single time we give a webinar, somebody asks, what's the difference between neurofeedback and Neurologics? And you can see that neurofeedback is the smart car on the left-hand side. And I'm not saying that there's not value for temporary symptom reduction. If I have a headache and I want to take a Tylenol, I am so grateful when that headache goes away. But it doesn't get at the etiology of why I had the headache. Is the headache blood sugar related? Is the headache tension headache through stress? Is the headache because I have a brain tumor? Neurofeedback doesn't answer the question. It is just symptom reduction while you're plugged into the neurofeedback machine. It is gaming for brain development. It's very easy to conduct, and it indiscriminately targets the cortex. The danger is that overtraining the brain can actually produce seizure. And so when I stress that the part of the brain that's already fully functioning, we don't want to address, because we're not fixing what's broken. What's not broken. We're looking at portions of the brain that are underperforming, and we're bringing those into alignment with the portions of the brain that are already performing in an optimal way. What we do is complicated. It's a medical technology product. It requires an expert. Again, we train only those areas which need training. We look at the root cause of the neurological dysfunction, and we produce synaptogenesis for long-term cognitive repair. Dallas, do you want to talk about this slide? I know this is one of your favorites.
Oh, the process. This is, I mean, obviously, it lists the steps in the process. Obviously, getting the brain map to start with, the baseline brain map, taking the. I said it does take 2 hours in order to be able to exercise every one of these different connections in all of the cognitive networks. Then obviously reviewing that with the client and so on is important. It takes an hour to do that first report generally. And then from that, as we've mentioned, the computer algorithms have determined hierarchy, which portions of the brain network should be worked on first, which are the more foundational ones. The brain sort of built in layers, if you will, in terms of its function, that, where you have to have a solid foundation. Things like working memory network and so on have to be solid before you can get the other parts of the brain networks to work properly. So determining which portions, what exercises are right for that individual, and how those exercises need to be tweaked for that individual is all part of that computer algorithm. Optimally, it's 3 1-hour sessions per week for about 24-25 sessions, and then getting a remap, because after those 24-25 sessions, we do see measurable change in the brain map. And that's determined then by getting a remap. Then from that is determined whether the actual exercise pattern needs, the different types of cognitive repair remediation need to be changed for the new map. But also that sets us off for then another round of optimization. It does take about 50 sessions for those temporary cognitive changes, those temporary synapses to become permanent. The actual shape of the connection changes as it becomes mature in exercise. So that's important for the long-lasting thing. Depends on how many layers there are. It determines whether they need to be doing 2 rounds or 3 rounds. In other words, 4 months or 6 months of it, and then a final map to show if they've achieved their optimum improvement. And from that, then there are very complex cases that need to go longer. Depends on it. Traumatic brain injury is one of the simpler ones. If you start getting into substance use, is maybe more a little bit and then if you get into developmental spectrum type of situations, that is the most complex of the conditions for this. So it just depends on this. But the big thing is it's permanent cognitive change, that you don't have to keep doing this for the rest of your life. Next slide.
This one is a report card that analyzes all of the different maps and looks for the overall improvement. And so when we do a brain map and then we compare it map 2 to map 1, you can see the change between maps 1 and 2. You can see what happens with the movement of this person's brain. And you can see that anything on the right-hand side in green is overall improvement of 1 standard deviation or more. And so you can see that this person, if you just really quickly look at this brain map and you say to yourself, okay, I work with clients, we all do, who say like, nothing's changed, nothing's better, I'm still just as sick as I was, I'm hopeless and I don't feel like futuristically that I have a lot of hope in my life. You're able to take the tool and say, that is not true. Let's look at, you have a 26-point improvement in current functional IQ. Your cognitive flexibility moved 12 points. Your fluid reasoning moved 11 points. Self-monitoring, 14 points. Your ability to think, 26 points. Your thinking efficiency moved, 24 points, right? Your processing speed, that's genetic and somewhat static across the board. Your spatial ability moved by 24 points total, 13 points between brain maps 2 and 3. Your ability to learn moved 26 points overall. The improvement between maps 2 and 3 was 25 points. Information retention, this one is profound, 52 points in information retention. The amount of stress that it puts on your brain if you can't recall or retain information is significant. So you can see that 29 points between map 2 and 3, 52 points overall. So this is sort of like the report card. If you're looking at what is my semester report card and what is my progress as I'm graduating, this is the mapping over time and the results that this person achieved from 9/20 to 11/5/2020.
All right. So there's the so what? Okay, we get numbers that change and so on, but what is the actual outcome? And these are some slides here. I know that we're getting long on the hour here, so try and go through these. So these are different groups, and so this technology is not label specific. It just looks at the brain connections and fixes them wherever they are. So for instance, in developmental clients, this is a series of 200 of them, and the kinds of increases that they achieved over their enrollment in the program, with improved general thinking, improved cognitive efficiency, and 26-point increase in delayed recall, which is one of the places where they particularly suffer. Let's go to the next slide. This is a substance use. This is a study of 115. We actually published a larger study of 321 here, but this shows that individuals who are enrolled in a standard inpatient setting and comparing the people who do the standard, 90-day program, and 24% of them are sober after 18 months. After discharge, whereas of those that did the standard program plus did neurologics and neuroengineering, 89% of them are still sober after 18 months. And you can see the before and after, all the different cognitive domains where there was improvement between the gray and the orange here in terms of these different domains. Many of these are particularly important in people with substance use disorder. The next slide. Traumatic brain injury, another paper that we published recently of TBI, the kinds of increases that we see across the board in terms of functional IQ, cognitive efficiency, working memory, delayed recall, and so on, improvements that are dramatic. And the people, obviously symptomatic, felt better as well, like Karen said. So next slide. I think one of the greatest areas this could have an effect on is people with sort of age-related or mild cognitive impairment, or they're just starting to, they're not in full-blown Alzheimer's or something like that, but mild cognitive impairment. That of those that came into the program with a diagnosis of mild cognitive impairment, after they completed the program, 89% of them were now tested as normal. After the other ones didn't hit the norm, but they had improvements as well. So, and next slide. So, Karen.
Sure. We value clinicians, and this is just for you to be able to pass along to your clients. For every client you refer, we will offer them a professional courtesy discount of $500 towards their brain map. And at this point, we'd like to take your questions. Do we have things in the chat box? Do people have questions? It's been a lot of dense material. The save the dates are on the right-hand side of the screen. Lisa set these at November 8th at 9:30. We're having an in-person coffee chat. The next webinar of how trauma affects the brain will be December 1st. That's a Friday at 9 a.m. A reminder of what kinds of cases you can think of us for. Anyone with a learning difference, anyone who's had multiple treatment experiences, anybody who you want a solid treatment plan and an analysis of their overall brain function for anyone who avoids school, anyone with any history of traumatic brain injury or concussion, ADHD assessment, anybody who is at risk of relapse or has a history of substance abuse or use. Same thing with gaming and process addiction. And again, we have found over time that a number of our clients have been able to reduce the number of medications they take. And parents have certainly become wise, especially over the last few years, to really being cautious about, and psychiatrists have as well, putting children on a stimulant for ADHD. Does anyone have any questions?
Well, we've hit the 3 o'clock hour.
Okay, well,
Well,
thank you.
with that, yeah, thank you so much, everyone, for joining. We'll make a copy of this recording available to you and for future reference. And if there are any questions, comments, concerns, please reach out to Michelle or Lisa, info@neurologics.com. And thank you all for coming, and we hope to see you at our next one.
All right. Thank you, everybody.